Now, the pancreas, all right, it's located inferior to the stomach, okay? It has three parts to it. We'll get in more into that when we talk about the digestive system. It's got the tail, the head, and the body. And it has it's a dual organ. Part of it, it's an exocrine gland, meaning that there's a duct there, and enzymes will go through the duct and go into the small intestines. But the other half, and that's why we're doing it here, the other half is that it's an endocrine gland. And an endocrine gland, the hormones, they'll go into a duct. They go right into the bloodstream and go off that way. So we have three different hormones that come from the endocrine gland, or I'm sorry, from the pancreas. Okay? First one is something called glucagon. Glucagon is a big glucagon is a hormone that when low levels of glucose are in your blood, glucagon is going to go to this big iceberg called glycogen, and please be careful of the spelling on this. All right? You have glucagon, and you have glycogen. Easily mixed up. This is a hormone. This is a polysaccharide. Okay? Polysaccharide is a big, long chain of branches of glucose, right? Carbohydrate, sugar. Okay? So what glucagon does is that if you have low levels of glucose in your bloodstream, we got to get the glucose into the bloodstream. So glucagon comes out of the pancreas and goes to the liver. The liver is loaded with glycogen. And it's a big iceberg of glucose. And glycogen is in the liver and in some muscle. But it goes to the liver, and the glucagon chips away at this glycogen so that if you have this big iceberg, it chips it away, and little ice cubes of glucose go into the bloodstream. And that's how that works. So glucagon is going to increase glucose into the bloodstream. That's how it does that. Okay? So it's not hormonally regulated. This hormone, glucagon, is not regulated by a hormone. It's regulated by some other non-hormonal substance. In this case, glucose. The amount of glucose in the bloodstream will direct if glucagon comes out or not. Another hormone. Okay? Then we have another hormone that I'm sure you're all familiar with called insulin. Insulin is going to come out of the pancreas when glucose in the bloodstream is very high. Okay? Glucose in the bloodstream is very high. It's going to tell the pancreas to spit off or release insulin. Insulin is then going to go to a lot of different cells. And it's going to open up the gates to allow glucose to go from the bloodstream into the cells. Or yes, it'll also go to the liver and put glucose back onto glycogen. But insulin is going to do everything possible, everything it can, to take glucose out of the bloodstream and put it elsewhere. Glucagon does everything it can to put glucose back into the bloodstream. You have this teeter-totter. As much as we see calcitonin is to PTH, insulin is to glucagon. They're both non-hormonally controlled. Okay? Now this is what happens. Let's say you're inside of a cell. Out there in the hallway is going to be your bloodstream. Insulin is not going to come inside the cell. It's not made to do that. Okay? What it's going to do, let me move this a little. Yeah. So you're inside of a cell. The bloodstream is the hallway. The doorway is your receptor. Okay? Inside the cell, it's low on sugar. You need sugar, you know, to make ATP. You need glucose, right? So you need sugar to come in here. So this is what insulin does. There's a potload of glucose out there. Glucose can't get into the cell. So what do? It tells the pancreas to release a hormone called insulin. Insulin is going to unlock the door, open it up. How it goes about doing that? We talked all about that with membrane-bound receptors and the you know, if it's a lipid soluble receptor, those kind of things. That's what we talked about over there. I'm not going to go and reiterate that stuff. But the insulin unlocks the door. That's all it is. An insulin is a key. It's going to unlock the door to allow glucose to come inside. The insulin doesn't come inside. It just unlocks the door to allow glucose to come inside. That's how that works. Okay? And that's going to decrease the amount of students or glucose molecules from the bloodstream. All right? Just think of that on a bigger scale, because there's a lot of cells it's going to allow to go in there. That's how insulin works. Now, let me talk briefly about diabetes, since that's the sixth killer in America, and I guarantee you will have questions on my test and everything else for the rest of your life. Okay? Diabetes is this. There's two types of diabetes. Well, three types, gestational during pregnancy, but we won't talk about that. But there's two types of diabetes. There's one type that's called type 1 diabetes, and everything I'm going to explain is on the next few slides over here. So yes, this stuff's important. I'm going to ask you stuff. Type 1 diabetes is that you don't have insulin. For some reason, your cells are not making insulin from the pancreas. So you just don't have insulin. It's an easy fix. You just give them insulin for the rest of their life. Well, when I say easy, I mean you got to give the right dosage and stuff. But that's what happens. Okay? That's not what grandma's got. That's not the more common one. The more common one is type 2 diabetes, which is a little bit more to it than just no insulin. They have insulin. They have insulin in their body. But what happens here is that the keyholes on the receptors for insulin have a lot of gunk on it. All right? Gunk. I don't know. Glue, super glue, silly putty, whatever you want to call it, is in there. So now when the insulin goes on top of the receptor, it's resistant. It's not working properly. So we sometimes call type 2 diabetes insulin-resistant diabetes. Because you have insulin, it's just not working. Meanwhile, the sugar is going up and up and up in the bloodstream. You've heard of that with people with diabetes. That's what's happening. It's because the glucose can't come inside the cell. So this is what happens. Inside the room, inside the cells, we need glucose. So it sends a message to the brain. I don't know why, as a teacher, I don't know why, the sugar is not coming in here. Maybe it's just because they got to put, you got to have more security to have more keys to unlock this door. I don't know. But let me explain to you what that gunk is in terms of how it got there. People getting obese, adipose tissue, causes a lot more of that gunk there. Okay? It just gets sticky, more glucose there. It gets more resistant. So look what's happening here. And this is why it's hard to control diabetes. Door's closed, sugar's going up. Inside here, inside the room, you're not getting glucose in here. So inside the cell sends a message to the brain saying, I don't know why I'm not getting any sugar in here, but we need sugar. So the brain says, well, I don't know why either, so you know what? We might as well get ourselves more hungry. Maybe that's the reason why. It's because you're just low on sugar, so you eat more. You see this vicious cycle that happens? No sugar in here, it's going to make you more hungry. And they're going to get more and more adipose tissue, which means there's going to be more and more gunk that happens on that receptor. This is why it's hard to control diabetes. Okay? So, this is my little promise to you. If you know anyone who's got diabetes, type 2 diabetes, I guarantee that if you lose 50 pounds, or that person loses 50 pounds, they will be off insulin. You can control it with diet, but this is what happens. If you control with diet, there won't be so much gunk on there, and the insulin could come in, not as well as a healthy person, but it'll allow it to come in. But if you have too much gunk on there, then what happens is the pancreas is going to send off more insulin. And that's not going to work. So sometimes you've got to give yourself exogenous insulin, shots of insulin. Because this is how the theory is. If I have a security guard here and he's having problems unlocking this, what's the next thing he's going to do? He's going to call 4 or 5 other security guards with their keys and see if they can unlock it. So what's happening here is that if you have 5 or 6 insulin keys, one of them is going to eventually get in there. With enough struggle, you'll be able to open up the doors. And that's what your body's happening over here. Is that if you can't control it with diet, we got to give you more insulin to try and open up the doors. But if you don't have that adipose tissue, the extra adipose tissue, you won't need to be put on insulin. You can control it with just diet. Does that make sense? Okay? It's that vicious cycle that goes on and on and on. All right?
By going on the diet and your body's turning off all that insulin because you're balancing it, now the insulin can get in more easier because of the diet?
Because you're getting more gunk off that doorknob. Okay? If you take off more, because the adipose tissue is what's putting all that gunk on there. So if you have less adipose tissue, you're going to have less gunk on there. You won't need insulin. You can control it just by a certain diet. That's basically how to do that. All right? Questions about that? That's type 2 diabetes, not type 1. Type 1 will always need insulin because you're not making insulin. That's a different story. But type 2, which is the more common one, you can control it. All right? Most people who have diabetes type 2, look at it. They usually have a belly on them. Okay? Maybe not big belly, but it's just what it is if they're on insulin. I guarantee you, knock off insulin. They won't be on insulin. They'll be a diabetic, but they won't need insulin. You'll just have to control it with diet or maybe a few pills, but not insulin pills. There's pills out there that actually make that more sensitive, that insulin can get on there, or there's pills that actually put out more insulin from the pancreas. All right, but you wouldn't need to do the shots per se. It depends. I don't want to get into talk about pharmacology too much, but basically that's what it is. And I have to talk about diabetes. I mean, we're talking about insulin and glucagon. Mm-hmm.
So, why are they still going to be diabetic if they have insulin up under the belt?
Because they're already diagnosed with being diabetic, that means they're prone of, if they add more weight to it, to their body, they're going to go right back into that whole thing. So they're known as diabetic, but diabetic without insulin or diabetic with insulin? Diabetic with medication, like pill medication, or diabetic without? Diabetic controlled with diet or diabetic not? You're already, not you, but one's already in a category. Once you're diagnosed with diabetes, it's just what's the treatment for it? Are you controlling it by diet, by pills, or by insulin? And that tells us level-wise how severe your diabetes is. I got diabetes, but I'm controlling with diet. But you'll always have it. It's kind of like congestive heart failure. Once you have it, and we'll talk about that later, you will always have congestive heart failure. Unless, of course, you get a heart transplant.
And how come people that are not obese have diabetes type 2?
They usually are obese, or well, not even obese, but more overweight. And sometimes you can't tell if they're overweight or not. But yes, there are. My father, he has diabetes. He was slim, and I can't explain it. He was slim, but now he's eating on. He's going back to his cold cuts and things like that. Now he's on insulin. So it's hard. People who have type 1 diabetes, they're usually slim though. Okay. Other questions? Yeah.
So like if somebody has type 2 diabetes and they're like really big and then miraculously they just like lose a bunch of weight, are they gonna ever get to a point where they like just don't need to worry about it, or is there always
No, there's always a point, because as we get older, our bodies change.
So no matter what, they'll always have
They'll always have it. They always have to be conscious about the foods that they're eating. I'm not saying, the thing is, a lot of people, I don't want to get into too much diabetes, but I don't want to say there's a diabetic diet. It's just you've got to change your diet. You can have a piece of cheesecake. You can't have the big piece that you're usually doing. You have a little sliver. There's ways that you can do exercise. Like my father, when he used to control it, he would walk around the block like, you know, one time, and then he knows he can actually eat at a barbecue because he just lost, you know, sugar goes down. He was never on insulin until just recently. He starts enjoying those cold cuts and, you know, burgers and fatty foods and stuff. It's just going to go that way. But did I answer your question? Yeah. I mean, you'll always be diabetic. You're always now prone. You're now labeled as a diabetic, and you just have to be conscious about it. You'll never have it where you're going to. There's certain cases you won't be a diabetic, like gestational diabetes. That's when you're pregnant. But if one's pregnant, they got pregnant because, or they got diabetes because of their pregnancy. But once the placenta goes away, now they're not diabetic. Certain medications, corticosteroids, cortisol, taking prednisone, taking that by mouth, that can also cause diabetes. But once you're off of that, then you're not. But I'm talking about naturally, if you get the diabetes, not caused by pregnancy or any kind of medication, yeah, you'll always be the diabetic. It's just, is it controlled with diet or controlled with pills or controlled with insulin? So, and as we get older, our bodies do change. I mean, it's a lot harder for me to lose weight than I was 21 years old. Right? Our bodies do change. Our immune system changes. You see a lot of people getting infections. You know, shingles is very common in, let's say, 60, 70, 80 years old, but not so common as a 15-year-old. Our immune system, and we'll talk about that later, our immune system goes down. Okay? Questions on that? Okay? Sound good? All right. Now, the problem is, when glucagon comes out, it always comes out. When insulin comes out, it always comes out. We need something to stop it. So we have another hormone called somatostatin. Somatostatin says, okay, our level of glucose is fine. We can stop the glucagon from coming out. So somatostatin is going to inhibit glucagon. It'll inhibit insulin when it keeps on coming out. Okay, so that's what that is. All right. It also is going to inhibit growth hormone too. So even though this is acting as a paracrine, meaning that these three hormones come from the pancreas, this goes to another cell, and you'll learn about beta cells. Beta cells of the pancreas is going to release insulin. So these are going to target the beta cells in the pancreas to stop it. This is going to go to the cells that release glucagon to stop it. So it doesn't need to go into the bloodstream. So why is this called a hormone if it doesn't go into the bloodstream? Because this can also go into the bloodstream and go all the way up to the anterior pituitary and stop growth hormone also. So there it is, a hormone also. In this case, somatostatin is a paracrine, which we talked about, and we also talked about a hormone. All right? It's very similar to growth hormone inhibiting hormone. And where is this found? Where is this coming from? Oh, hypothalamus. All right. Remember, it has the word inhibiting or it has the word releasing in it. It's coming from the hypothalamus. Okay. All right, glucagon. It's a hyperglycemic agent. It's going to put glucose into the bloodstream. Okay. Like I said, it targets the liver, and it also has, some muscle also has glucagon. I'm sorry, glycogen. Okay, I did that thing where I should have. It's going to break down glycogen, become glucose. So glycogenolysis, right? Lysis of glycogen. Lysis means to break up. Or it's going to make new glucogen, or we're going to make genesis is to, like genesis, you're going to birth, right? It's going to make new glucose from scratch, from amino acids, right? You learned that from your biology course. What I'm trying to show you is that it's going to do two different ways to get glucose into the bloodstream, okay? So just be careful, word alert. We're going to talk about other things too. All right, you have glycogen up there, glucagon, glucose. There's also things called glucocorticoids and also gluten, right? Gluten-free diet, that kind of stuff. So just be careful. There's a lot of words that look similar. Insulin is a protein hormone, and it's a hypoglycemic agent, right? It's going to do everything it can to get glucose out of the bloodstream and go to put it somewhere else, okay? So it's going to decrease blood glucose levels, transport glucose into the bloodstream, as it kind of shows you. It opens and unlocks the doors to allow glucose to go into the blood, go into the cells. Okay. And this is just, it looks like busy, but it's everything I just explained about. You got high levels of, well, let's start here. Low levels of glucose or sugar is going to tell the pancreas to spit out glucagon to go to the liver. It's going to target glycogen, and it's going to break the glycogen and raise the sugar. When the sugars get too high, it tells the pancreas to release insulin to tell the glucose to go into the cells, or it's going to tell the glucose to go back into glycogen. Either way, it's going to lower the blood sugar levels. Okay? So it's just a summary of what I just explained there. Okay? All right, again, it's about the histology. All right? And what it is that it's broken down into two things. Keep in mind the pancreas is a dual organ. Part of it is going to be exocrine, and part of it is endocrine. As an exocrine gland, it's going to release a lot of enzymes. Enzymes are going to help digest your food. It has a duct that goes into your small intestines. We're going to stress more about that when we get to the digestive system, okay? But what I want you to understand is that the cells of the pancreas that make enzymes are cells called the Yersinia cells. And it makes up 99% of the pancreas. So yes, only 1% of the pancreas is endocrine related. Yet, we always talk about insulin and glucagon. Yeah, they're just as important. But these cells, well, I'll explain it to you, all right? So 99% of the pancreas is making exocrines, or I'm sorry, making enzymes. So the other part, which is only going to be 1%, is things called the islets of Langerhans. Now, what this is, it only makes up about 1% of the pancreas. That's it. It's scattered throughout the whole pancreas. So you take these islets of Langerhans and squish them all together. It's only in this one little section area of the pancreas. Most of it is exocrine. A little bit is endocrine. But it's equally as important. Okay? The way we break up the islets of Langerhans is that there's different cells in there called alpha, beta, delta, and F cells. Okay? Easy to do. It's just a flashcard kind of memory thing on here. Basically what we have is that the alpha cells are going to synthesize glucagon. The beta cells are going to synthesize insulin. Delta cells make somatostatin, and don't worry so much about the F cells. I put it there to be complete. But the main ones you need to know is the alpha cells and beta cells. And as you grow into this medical field, you're going to learn more and more about the beta cells with diabetes, how you can actually make the insulin come out faster for people who have diabetes. For people who have type 1 diabetes, I explained to you that it's an autoimmune disease that attacks the cells that make insulin. In this case, it attacks the beta cells. And the beta cells can't make insulin. So people with type 1 diabetes are going to be on insulin for the rest of their life. So yes, there's some talk about taking beta cells from pigs and trying to incorporate them into humans with type 1 diabetes. And that's where you're going to be learning about that. Okay? Questions about that? It's not too bad on it. It's just memorization. Alpha and beta cells. And what it looks like is that if you can see this is a close-up. This is an islet of Langerhans. Can you see that area there? All right, let me just turn off the lights a little bit. Show up well. You see it? This is an islet of Langerhans. Okay? All the dark blue surrounding it is Yersinia cells that are making all the enzymes. That's making up about 99% of the pancreas. Only 1% is made up here, and these are scattered. There's one here, there's one over here, there's one over here, there's one over here, and so forth. But they only make up 1%. This is what's making the endocrine system. And inside there, you should be able to, well, you would see alpha cells and beta cells. But like I said, the microscope slides are not very good that you can see that. But you should know in theory what beta cells do and what alpha cells do. Okay? Questions about that? So deficiency is what we call diabetes mellitus, not diabetes insipidus. Diabetes insipidus was a decrease of ADH coming from the posterior pituitary. That's totally different. Diabetes mellitus, and that was a rare disease. Diabetes mellitus is the more common one. This is what grandma's got. Okay? This is the #1 endocrine disease, #1 risk for coronary blood or coronary artery disease, and it used to be the 6th killer. Now it's the 7th killer. They're moving about, and you should know those. You're going to see. I'm going to put these in order. When we get to the last class, you'll see all these the top 10. You should know the top 10 killers of America in America. And you should write those down. Those are critical for you to know. Why? Because when you become a nurse, when you become a radiographer, when you become a physical therapist, an occupational therapist, a physical a PA, those are where the questions are going to go. They want to make sure that you are exposed and have a lot of knowledge on the 10 killers in America, because that's what they want to see if you. Because those are the people that are coming into the hospitals, coming into the offices. So they want to know if you could actually know that. Okay, so they are going to have a lot of questions on it. Are they going to have questions on Down syndrome? Yeah, but it's not one of the 10 killers. You may have like 1 or 2 questions on that, but you know, cancer, they're going to have probably about 30 questions on that. That's the #2 killer. All right, so you should know the top 10 killers. Okay, what's the #1 killer of women in this country? Heart disease. Yeah, I used to have people saying breast cancer. But heart. So this is when we have a decrease of insulin or insulin resistant. So if you have an increase or a decrease of insulin, you're going to have a lot of glucose in the bloodstream, i.e. hyperglycemia, right? And you'll get these things. Since there's so much glucose in your bloodstream, your kidney is just going to manage that and say, hey, we can't put it right back into the bloodstream, so you're going to pee it all out. You should not have glucose in your urine. And back in the day, the 1800s, diabetes mellitus, what that meant was sweet-tasting urine. And they used to do that back in the 1800s. They used to taste it. Things have changed now. But that's how they used to do that. All right? So you would have that in there. Polyuria, for every molecule of glucose that goes into your bloodstream to keep the concentration there, we have to have a molecule of water to go with it. So therefore, you're going to have more urine. Does that make sense? The volume of urine will go up. And we call that polyuria. And because you're losing so much water, you're going to get really thirsty. We call it polydipsia. And as I showed you before with that analogy, since glucose is not coming into the cells are going to tell your brain, get hungry. So these people also they increase their appetite. And these are the kinds of things that you should see. If you're not sure, let's say your mother starts, you see her getting up 3 or 4 times in the middle of the night, going to the bathroom. You see her drinking a lot of soda. You see her eating a lot. You put things together over here. It's like, Mom, why don't we check to see what your glucose is like? There's a lot of signs here that say that you might be leaning towards diabetes. See what I'm saying? It might not be, but it's being able to be keen on that and guessing what that is. But it makes sense. You can memorize this, or better, as I said before, understand why you would get these symptoms. And it will make sense to you. Okay? So there's 3 types of diabetes. The one here I'm not really going to get into, but it's gestational diabetes, right? Gestational diabetes occurs in pregnancy. It's basically, there's a hormone that comes out of the placenta that somehow blocks insulin on those receptors. But once you remove the placenta, then it works fine. The thing here I want you to understand is that 1 out of 5 women who have gestational diabetes becomes a diabetic themselves. Not the child, the mother. So 20% of women who have gestational diabetes become diabetic within the next few years. So we should keep an eye on that. Then we have the type 1 diabetes, which is an autoimmune disease. And that's where, for some reason, the cells are being attacked, which are called beta cells in the pancreas, are being attacked by these autoimmune antibodies, so that the beta cells can't make insulin. And that's what happens here, okay? Usually that's a young age that usually gets this. I think I had a patient, not a patient, I had a student a couple years ago. He was diagnosed with type 1 diabetes at 30 years old. That's usually pretty late. I don't usually see that. I usually see it 15, 20 years old or so, or even 8 years old for that matter. But they can't make any insulin, so they're going to be on insulin for the rest of their life, okay? But the type 2 diabetes, that's what grandma's got, right? That's the insulin-resistant one, okay? And we would say about 90% of all diabetic cases are like this. This is risk factors, number one risk factor for coronary artery disease, CAD, which leads to heart attacks, okay? Other risk factors to get type 2 diabetes is age, as you get older, obesity, and family history, okay? And this is just a chart form showing the two different types of diabetes. Mm-hmm.
For the type of diabetes that you get when you're pregnant, and then the 20% who get it later, what types of diabetes that they get it later?
Usually this one, because you wouldn't get type 1 at a later age. You know, if they're like 35, 40 years old now, it's usually this one that happens. Mm-hmm. Yeah. Type 1 is not very common. It happens, but it's not very common. Okay? And these are people that have diabetes, right? Tom Hanks, Sully. Also, I want to also mention too, if you're diabetic before you're pregnant, it's hard to get pregnant. All right? It's with the amount of glucose that's in the bloodstream could actually destroy the baby, cause miscarriages. And if you followed anything about Halle Berry, it was very difficult for her to get pregnant. All right? She has type 1 diabetes. She has the rare one, all right? But then, I don't know if you know who Delta Burke is from Designing Women. This was a show back in the 90s. But I think you all know Randy, right, from American Idol and stuff. So they all have diabetes. It's pretty prominent, okay?